Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Garland.
Hi, everyone. We're back, ACG 2022 at the ACG Annual Scientific Meeting in Charlotte at the Charlotte Convention Center. We're here with the amazing Dr. Tauseef Ali, and he's got a host of titles for us today. The first is he is the chair of the ACG PR committee. He is also the governor, the ACG governor for Oklahoma. And then, because I'm not going to butcher this, I'm going to read it. He is the medical executive director of SSM Health Digestive Institute. He is a phenomenal doctor, gastroenterologist, but he's also an amazing patient educator. He does a lot on social media. And we are so grateful here today to have him, because we're talking about a very sensitive topic and a very potentially embarrassing topic for a lot of patients, and we're talking about bowel urgency. So, Dr. Ali, first of all, welcome.
Thank you, Jackie, for having me today.
Oh, it's a pleasure.
It's my pleasure. Always a pleasure
It
talking
is.
to you.
So, before we get into it, can you just explain what bowel urgency is?
Yeah, I think it's an excellent question, and to be very honest, frank, and transparent, until about maybe 6-7 years ago, I myself didn't know how to ask patient about urgency, tenesmus, incontinence, because patients don't know how to describe their symptoms. And as a physician, we sometimes use just medical terms, feeling that the patient would understand. So it's very important in terms of our education as well as for patients to understand when physicians are asking them questions or inquiring about their symptoms, what does that mean, and how to then describe those symptoms and their problems. So bowel urgency, it's different than incontinence. I call it's one step towards incontinence. So before incontinence, you get urgency. The way I understand it and the way I describe to the patients is that you have this urge to go. And if you don't have a place to defecate or to poop, you may have an accident. So you have that fear that I need to go to the bathroom because I just need to rush. And if I don't, I may have an accident, and sometimes patients do admit that they have accidents. And some patients ask me, so Dr. Ali, what do you mean by that? Because they sometimes know urgency, like urinary urgency,
Right.
that when they cough, when they laugh, they have leakage, and they sometimes think that's also fecal urgency or fecal, they confuse, and sometimes they call it diarrhea. So first of all, let me explain to you why it's important, and then I will explain to you what actually it means. It's important because the patients, when you ask them, are you having diarrhea? And they consider urgency as diarrhea. So they may be telling you an incorrect information that may impact your therapy plan.
So, can I interrupt you? So, we're talking about patients with inflammatory bowel disease, or are we talking
Yes.
about all patients?
So for now, I'm just talking about urgency, but we are relating it to inflammatory bowel disease.
Great.
So it could be IBS, it could be IBD, it could be many reasons people get urgency. So it's important for us to understand what urgency means. So the way I describe to the patients, now let's go to the definition of urgency. This is how I explain to the patient that when you have your fecal matter or your poop coming from your large intestine going to your rectum, which is the last part before you defecate or before you poop out, that rectum can hold your poop to a certain time. And then when it is socially indicated, or when you feel like this is time to go to the bathroom to poop, or restroom to poop, you go and you defecate. Sometimes because of inflammation in inflammatory bowel disease, or for many other reasons, sometimes your rectum just is sensitive. And that can happen in IBS, it can happen in diabetic patients, it can happen in patients who have neuropathies or pelvic floor dysfunction or disorder. So all these conditions can make your rectum very sensitive. So anytime the poop comes to your rectum relaxes and it accommodates. But when you are hypersensitive, when you are inflamed, it cannot relax, and in fact it contracts because it has to get the poop out because it is super sensitive, it is hypersensitive. When that happens, you have your last line of control are your anal sphincters. So you have two types of anal sphincters. One that is made up of smooth muscles, it is controlled by nerves, and then there is a striated muscles that you consciously control. So when you have a problem of urgency, the stool comes to your rectum forcefully contract, and your internal sphincter relaxes. So the only thing that is preventing you from having an accident is your external sphincter. And you can't just consciously control that sphincter for a long time. So that's why you rush to the bathroom, you try to find a place where you can poop, and sometimes you may even have an accident if you can't hold your external sphincter contracted for a certain period of time. So that is called urgency, the feeling that you just need to go because your rectum is contracting, your anal sphincter is already relaxed, and the only thing that's holding that poop to come out is your external sphincter that you are consciously controlling. So that's called bowel urgency. And as I described, bowel urgency can happen when you have inflammation in the rectum, proctitis. It can happen without inflammation also. For example, in Crohn's disease, sometimes you don't get inflammation in the rectum, but still patients get urgency. And it can happen in diabetic patients, as we discussed, patients who have received radiation therapy for prostate cancer. All these things can cause bowel urgency.
Interesting. So, Dr. Ali, in terms of incidence, how many people are affected by bowel urgency, particularly with the IBD patients?
Yeah, I think this is a very excellent question because we don't discuss urgency in our practices as often as we should. We mostly ask about diarrhea, we ask about pain, and we ask about bleeding. We don't specifically ask about urgency, which is a very important symptom. And studies have shown that more than 50% of patients, it could be as high as 60 or 70% in ulcerative colitis patients, that more than half of these patients suffer from bowel urgency.
Wow. And, you're a great doctor, and there's a lot of great doctors here at this conference today, gastroenterologists. Why aren't you asking about it?
For two reasons. Number one, it's difficult. It's a difficult conversation when it comes to your poop, your defecation, and the framing of the question, and it's tough. So you need to develop a script how you're going to ask, and sometimes we don't have that training about how do we ask that question to our patient. That's number one. And number two, the reason is that we until very recently, we haven't appreciated that bowel urgency is a very debilitating symptom for our patients. And we were thinking that diarrhea is the most common and a symptom that affects your quality of life, but we are now recently, and you will see that during this ACG also, we have papers describing bowel urgency, its an impact. So now we have realized that it has a huge impact. So I think that's the reason we were not asking was lack of awareness, lack of a script, lack of description on our part, and then also the patient. They don't understand these terms. So sometimes you have to ask them differently, and until recently we didn't know that.
Yeah, and I think that brings up a good point because I was going to bring up about the patient's role in this. It's important, but before we get to that, I want to ask this question. So bowel urgency, you can have bowel urgency, but it may not present as diarrhea. It could just be you have to go to the bathroom really quickly, and it's not going to be diarrhea.
Yeah.
And that's different.
Yes.
We all know, most of us have had diarrhea at one time or another, and it's like, oh my God, I got to get to the bathroom quickly. But it doesn't mean bowel urgency is a little different.
Yes.
Because it could be a normal bowel movement, but you have no control of when it's coming out.
Absolutely. There are studies you're absolutely correct. There are studies that even sometimes patients with constipation in IBS can have bowel urgency. So bowel urgency is a totally separate entity in itself, a separate symptom that has an impact in IBD.
And this brings me to my next question. We know that the doctors aren't laughing at us. They're not laughing at us when we bring up topics. How can the patients help the doctor understand that they're having bowel urgency? Like, what can we do better as patients to explain, when we have an appointment? How can we describe it, or how do we bring it up?
Well, besides reading my book, Crohn's and Colitis
I
for
know,
Dummies,
talk about
where I explain this to the patients about what bowel urgency is, how you can describe it, how you can talk to your patients. It's an open dialogue. It's where patients need to cross that barrier line where they feel shy. Describing. And one way that I have always encouraged in my practice, and that could be a good resource, I give patients a card like this that says what questions you have for Dr. Ali today, or what are the most impressing symptoms that you want to discuss today. So sometimes patients are very hesitant to talk about bowel urgency. So they just write down and they describe in their own language. They don't feel embarrassed talking it out. So I just get to read it and then I talk to them. So sometimes small tricks like
clever. I
this
love
can
it.
help.
I love the fact that you describe this in your book. So what is your book called?
Crohn's and Colitis for Dummies. It's actually a second edition now.
Well.
So yeah.
So what are the highlights, and I especially about as it relates to bowel urgency?
So there's actually a huge there's actually a chapter that talks about how to describe your symptoms to your doctor.
That's wonderful.
So then it goes into this bowel urgency, incontinence, diarrhea, how they are different, why you get those symptoms, how you describe this to your doctor. Because many times patients would come to you and say that, I'm not better. And you ask them how many bowel movements you're having. Oh, I'm having 2 bowel movements per day. Well, then how are you not better? Are you having pain? No, I'm not having pain. Are you having blood in your stool? No. So then doctor's like, well, you are fine. So what is wrong with you? And the patient still cannot tell you, because we will talk about this, is that how it's affecting their social life, their emotional living, and as well as the physical symptoms of it. So sometimes when you ask the patient, so how is it affecting? Well, I can't go anywhere because I have to look for the bathroom. Well, you're having 2 bowel movements, so why do you have to look for the bathroom? Then they will tell you, oh, because I have to rush to the bathroom, because they don't know how to use the word urgency. So then you have to go in a little bit more detailed questions, so open-ended questions, and then kind of like taking them with you, describing what actually is bothering them. So sometimes that helps.
So this may be a weird question, but the word bowel urgency, maybe patients aren't using that enough to describe their symptoms. Is there something that you're seeing, a common word that they're using instead of bowel urgency? Or does it vary because the patient...
It's highly variable depending on patient willingness to describe. They may even know, but they just feel shy. It also varies if they have someone with them. Sometimes they have a partner with them and they just feel shy talking. A family member, mom, dad, brother, sister, friend, that really impact how they're describing their symptoms. And then sometimes the level of education. So variable factors that lead them not to describe exactly what's going on with them. So they may use the word, I'm just not feeling well. It's still bothering me. I can't finish. I'm not working. Can you fill my FMLA paper because I can't work? And you look at them and you say, I just ask you all these questions. So and that's the urgency, because they just can't work on a station or desk.
Like, how do you say that you're unable to work because you have bowel urgency?
Yeah. So.
And I mean, we understand that it's probably horrible. They have to jump out of their seat every 5 minutes.
Yes.
Run to the bathroom. The employer is going to think they're goofing off.
Yes.
So what do we need to do here? What do we need to do to fix this? I mean, talking about it, and patients. We've all experienced at some level or another, whether we have IBD or we have stage fright, or we're getting ready to go to the doctor's office and we're so nervous that we have to run to the bathroom. I can't stress enough how important it is to be as descriptive and as honest as you can with your provider. And I know it's embarrassing, but sometimes all the time know that your doctor is not there to make fun of you, right? You're not going to make fun of me if I say, Dr. Ali, I urgently have to go to the bathroom a lot. Like I feel like it's not diarrhea, but I have to go to the bathroom and I have to run, or I'm afraid I'm going to have an accident in my pants.
Yeah, I think this is an excellent point. Reassuring the patient, developing that relationship with the patient where they can describe this, because I tell them sometimes, not jokingly, not in a way that they take it negatively. I tell them, I'm your poop doctor.
Love it.
That's what I
You
talk
do.
about. That's what. So sometimes they are embarrassed showing me their poop pictures. Like, look, I'm having this blood in my stool. Nobody's believing me. Look, this is my toilet picture that I took out. So I think you have to break that barrier. You have to bring the patient to the comfort zone where they are open to these, because it's in their own benefit. Because that's how I would know that you as a patient suffering from an urgency, and I need to pay attention to this. I may need to adjust your therapy. I may need to provide you some more guidance. I may need to give you some more interventions to do to help you improve that symptom. If you're not going to tell me, I'm not going to act on it.
No, I'm so glad we're having this conversation, because we're sitting here like two adults. You're the doctor. I'm coming from the patient side. And it doesn't feel embarrassing. Like we're trying to normalize it for patients in the experience and their families. Like, imagine being a young person with IBD who just started dating, and I mean, how do you cope with that? Like, it's like, what do you say? Like, how do I tell my significant other that I have this problem?
Absolutely. I was about to say that when you were making this comment. Some patients who have lived their journey with IBD, they are more open to describing their symptoms. When you are newly diagnosed, you even don't know what's going on with your body. And then on top of that, if you're young, especially kids who don't know. I mean, IBD can happen to as young as 1 year old or even younger, right? So imagine a 6-year-old and 10-year-old having an IBD and unable to describe this urgency, and all he's used to is just wearing a diaper. So I think that education on the parents' part, they're the significant other, family members who can help them understand what urgency is. And as a doctor, as a physician, as a provider, our job is to just ask them directly and describe to them what urgency means. They may be, oh yeah, that really happens to me. Well, thank you for asking me this question, rather than just having this closed-ended question. You have urgency? No. You have diarrhea? No. You have incontinence? No. You have tenesmus? No. Until one day the patient asked me, what is tenesmus? And I took it kind of like a surprise. And believe me, this is like 10, 15 years ago. I did not know how to describe tenesmus myself. I have to open a dictionary to see how do I describe tenesmus to my patient?
What is that?
Yeah, so it's that feeling that you have to go, and after the evacuation, you feel like you still have to go.
Maybe there's something in sign language like, oh.
Yeah. So I think these terms, no matter how embarrassing these is, we need to tell our patients that these are impacting their quality of life, their social life, mentally. And
It all goes together. It's like we want patients to live well, live their best life, even if you have a condition like IBD. So that brings me to my next question. And how does a patient cope with this? Like, what can they do? Like, we know that there's diapers that they can buy, and now I think on the adult market they look like regular underwear, correct?
Yes.
We've seen the commercials. They're kind of making it not a big deal. And that's what, how do you talk to your patient about that, and not for the patient to be scared of doing that?
Yeah, so I think the first thing is you tell the patients that this is something that we can address. There are some interventions that we can help you with. So that's first part, the reassurance part. If this is secondary to inflammation, you take care of the inflammation. A lot of patients are hesitant to going up on therapy or dose adjustment, feeling like they're not having any bleeding. So that's it. That's good enough. But when you talk about urgency, you bring that up, how it's still impacting, because they may feel like this is their new normal now, that they have Crohn's disease, they have ulcerative colitis, they are not having bleeding. That's good enough for them. That's a reward enough for them that they are not even thinking consciously that they can still improve their quality of life. They can still have a normal life. So number one is education and reassurance. And then the second thing that you talk about, the interventions that you can do.
So there are things you can do. So,
Yeah.
the thought of wearing a diaper probably freaks a lot of people out. It's not a bad thing, because it may give you the extra security.
Yes.
But I love that you said that you're giving hope to patients that there are interventions and it's not necessarily what they may think. So that's why it's so important, Dr. Ali, what you're saying is that it's important to talk to your healthcare provider about it. However you need to describe it, try to be as open and as descriptive as possible so that they can help you with the right treatment. And are there options, interventions for someone with bowel urgency?
Yeah, so it depends why you're getting the bowel urgency. As I was describing, let's categorize it. So number one is the inflammation. So you need to make sure that the rectum is not inflamed in IBD. The other reasons, and one of the common reasons that I see besides inflammation urgency, is anxiety. So sometimes when you're anxious, when you're stressed, it increases your visceral hypersensitivity, and then you get urgency. So you need to break that cycle, because it may be the urgency driving your stress and anxiety, and then anxiety and stress is contributing and making your urgency even worse. So you break that cycle. So that intervention sometimes can help. You address their anxiety, you address their stress by different interventions, medical, non-medical interventions, right? The third is sometimes if there is no active inflammation, you can tell them about how they can change their diet. That can help. You can help them with some anti-motility drugs that can help improve the strength of your sphincter, and the medical therapy. And then physical therapy. So there are pelvic floor exercises that can help with urgency. So the idea is that all these interventions may not be right for you, but that's where, when you're going to talk to your physician, you and the doctor, you and the provider will then find out what's the best way to address that.
And this is so important because there may be something underlying causing the bowel urgency that has nothing to do with the bowel urgency, but what can we do to fix it? But that's why you have to be honest with your physician and talk to them, even if it seems embarrassing, because it's not going to be as embarrassing as you think. They've seen and heard it all, right? You've probably seen and heard a lot of things. Nothing probably shocks you anymore.
Yeah, I think that's the barrier that most of the time patients have to cross and be open about it so that we can provide them the best care.
Well, this has been such an amazing conversation. I hope, patients, that you're not afraid to talk about bowel urgency or running quickly to the bathroom, however you need to describe it. Understand that there's hope, there's ways to manage this, but the first line is to talk to your provider as openly and as honestly as you can so that they can find the right treatment and management for your condition. So thank you so much, Dr. Ali.
Well, thank you for having me. I hope it was a valuable information.
I hope so, and I hope if you're listening at home that you really take to heart all the great tips that Dr. Ali gave and have the right conversation and the open conversation with your provider. Thank you.
Thank you.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.